today we are going to discuss access cavity preparation. Okay, for that, uh, access cavity preparation. It is the first step of root canal treatment. Am I clear now? Yes, am I clear? My voice is clear. Siley, are you able to listen me?
Yes, ma'am.
See, access cavity preparation. It is the first step of the root canal treatment. Okay, what is a root canal treatment? You all of you know. See, it's a major part of conservative dentistry. Um, when we do the root canal treatment, first of all, see, pulp. It can be damaged. What you say? It can be damaged reversibly or irreversibly. So when the pulp it is irreversibly damaged, means it cannot be repaired back to its original thing. Means pulp cannot become vital. Pulp is irreversibly damaged. In that case, we do the root canal treatment. So, in root canal treatment, what we do? We remove the damaged pulp, the irreversibly damaged pulp. The pulp it is irreversibly inflamed. That pulp we remove in root canal treatment. Then, after removal of pulp, the pulp cavity we disinfect with some disinfecting material, and then we again fill that pulp cavity. This is the root canal treatment. So what is the root canal treatment? We remove the damaged necrosed pulp. Okay. And then the pulp cavity we disinfect with some disinfecting medicament. Okay. And then we fill it with some filling material. So in order to remove that necrosed pulp from the pulp chamber and from the root canal, we have to prepare some cavity. Okay, so in order to remove the necrose, damaged pulp, okay, we have to make the cavity in the tooth, and that cavity is called access cavity preparation. Okay, so today we are going to learn access cavity preparation. So in that we are going to see one second. We are going to see introduction. See, and when we want to remove the pulp, we should know how is the pulp in the pulp chamber, how is the pulp in the root canal. So we should know pulp canal or pulp morphology, we should know the pulp space morphology. Then we are going to learn definition of access cavity preparation, objective, principle, and important point is the anatomy of the pulp chamber. Okay, otherwise you are not going to locate, you are not going to able to locate the canal orifices. Okay, for doing by access cavity preparation there are certain rules we need to follow, so that are called guidelines or principle. Then instruments required. Then canal configuration means there are different root canal configurations are there that we are going to learn in this. Then cavity preparation for anterior and what mistakes the beginner does, that we are going to learn. The cavity preparation for premolars and the errors that operator makes. Then access cavity preparation for molars and then mistakes. Then what are the difficulties in uh, difficult canal preparation, that is like a C shape or calcified canal, or you can say uh, because of the older age the bulb chamber size is decreased. These are the difficulties that we are going to discuss in this part. Okay, so starting with this, just now I told you what is when we do the access cavity preparation. So we do the access cavity preparation when we have to do the first step of RCT. And why we need to do RCT? To remove the necrosed pulp or irreversibly damaged pulp. So the cavity which we make to remove properly, see, we need to remove the necrosed pulp properly. So there are some cavity preparations, we have to some principles of cavity preparations are there that we are going to see in the access cavity preparation. Okay, access means it is the to get the access to the pulp chamber. Okay. See here, just now I told you, these are the steps of root canal preparation, access cavity preparation. Then we determine the length of the root. Okay. Then we do the cleaning shaping, and then we do the obturation. So why this is a pyramid? Because if this steps fails, this is going to fail, this is going to fail, and this is going to fail. Okay. So important wise, access cavity, it is simple, but it is very important. If this cavity preparation fails, this pyramid will collapse. Okay. So most important step of the root canal treatment is access cavity. That's why it has been shown in a pyramid shape. Okay. And these are the steps of RCT. See, we have to remove this pulp. Okay, so we should know the pulp space morphology. Suppose in case of anterior tooth there is only one canal, but in case of anterior and mandibular tooth, the canals, there are chances that you may get a two canals. Okay, in premolars, all of you know that there is a lower premolar, only one canal is there. But percentage wise, if you see 20 to 30% of the cases in lower first premolar, you will see the variation. You may get one, two, or three canals. Okay, two or three canals. So for that reason, you should know the pulse space morphology. I I feel that all of you know this pulse space morphology very well. Only two things I want to tell you. This is the lateral canal. Okay, and one more thing I just want to tell you here, there is the accessory canals. So what is the difference between lateral canal and accessory canals? Here you can appreciate accessory canals. See, the lateral canals, they originate, or they, what you originate we cannot say, it is the lateral canals, they open up on the lateral side of the root canal. And here the accessory canals, they open up in the apical one third. So this is the definition. This is the Viva question. They may ask you what is the difference between the lateral canals and accessory canals. See, accessory canals, they open up in the apical one third, and lateral canals, they open up in the lateral surface of the root canal in the middle and coronal one third. Even if in the percussion area, if this is the canal, it is opening up in the percussion area, it is also called lateral canal. Okay, the percentage of lateral canal, it is in the percussion area, and in the apical area, the accessory canals, they are more. So here is the definition which is given by Stephen Cohen. I will suggest you for this, you go through for the Grossman definition. Here it is Stephen Cohen's definition. Access cavity preparation by Grossman is, it is a cavity preparation in the coronal part of the tooth to get an access to the into the, sorry, to get an access to the canal orifices and to get a straight line access to the apical foramina. This is given by Grossman. This is the cavity preparation done to remove the pulp from the pulp chamber and the root canal, and to explore the canal orifices and to get the straight line access uh, into the apical foramina. Okay, so you please read this only and you just tell this only, don't go for the Stephen Cohen. Okay. So what is the objectives of access cavity preparation? See, the objective of the access cavity preparation is you should get a straight line access to this apical foramina. It should not be, see here, we get the straight line access to this apical foramina. Okay, so we want a straight line access. Your instrument should go straight line wise. It should not obstruct in the pulp chamber, or it should not obstruct in the pulp chamber floor. We should get a straight line access here in the till your apical foramina. This is the objective of access cavity preparation. We want straight line access into this apical foramina. Your instrument should not obstruct in this area. in the pulp chamber area. Okay. In addition to that, we should remove all caries present over here. We should remove all restorative material present here. And in addition to that, the other that in addition to that, I just told you, your instrument should not get obstructed in the pulp chamber area. How it won't get obstructed in the pulp chamber area? If you properly unroof the, sorry for the spelling, okay? It should not, it is like here, you have to remove the pulp chamber floor, roof of the pulp chamber completely. So unroof the pulp chamber completely. If you do this step properly, your instrument will not get stuck in the pulp chamber area. Your instrument should go straightwise into your apical foramina. See, canal curvature, we cannot do anything to the canal curvature. But in the pulp chamber area, because of restoration, because of the caries, because of the tooth structure, this instrument should not get deflect in the pulp chamber area. This is the objective of access cavity preparation. For that, we have to make a straight line access. Okay. So next objective of this is the secondary, you can say, remove all coronal pulp tissue completely. See, if you get the straight line access, if you remove, you are going to get the complete removal of the coronal pulp tissue. Okay, and if you remove complete coronal pulp tissue, it will be easy to locate the canal orifices. See, canal orifices is the term which we see, the canal openings which we see on the floor of the pulp chamber. Am I clear? समझते का? Canal orifices, it is the openings of the root canals which we see on the pulp floor, and canal apical foramina, it is the different thing. Okay, we need to access cavity. Objective क्या क्या है? One is to get the proper straight line access to apical foramina. We want straight line access to this apical foramina. And next is, it will be easy to locate the canal orifices. So here you are going to locate 3 canal orifices at the floor of the pulp chamber. Am I clear? Next, straight line access to apical foramina to the initial curvature of the canal. Just now I told you, you want to have a straight line access to the apical foramina. Your instrument should not get stuck in the pulp chamber and in the coronal 1/3. Okay. So, principles. Just like a cavity preparation, we also have a principles for the access cavity preparation. In that, first is the outline form. In that again, different sub principles are there, size, shape, that we are going to see in detail. Then convenience form. Like your cavity preparation, here also convenience form is there, that is to have a good visibility. Okay, convenience form is like your cavity preparation, it is similar. We should have a good visibility of what? Here it is of the canal orifices. It should have a good visibility to remove the pulp tissue from the pulp chamber, to remove the pulp tissue from the root canal. Okay, then removal of remaining caries, denting and defective restoration, like your cavity preparation. And again, similar to your cavity preparation, toilet of the cavity. Here we want to remove all the debris from the cavity. So these are the principles of the access cavity preparation. Okay, it is similar like we have in a operative dentistry, principles for the class 1 cavity, or principles for the cavity preparation, isn't it? Similarly, here we have a principles for the access cavity preparation: outline form, convenience form, removal of remaining caries, denting and defective restoration, and toilet of the cavity. This we are going to see in detail. Just now I told you outline form. Okay, so this outline form, it is, what is this? This is the outline form. This is the outline form. See, the outline, it is similar to the external surface of the tooth. Means like in the cusp area, pulp chamber will have a projection, isn't it? You all of you know this. Okay, your external surface, your internal surface, or you can say the pulp chamber, it mimics the external surface of your tooth. The pulp chamber mimics the external surface of the tooth. Means pulp chamber of the external surface of the pulp chamber is similar to the external surface of your tooth. Okay, this is the outline form. Just now I told you size of the pulp chamber. And in outline form, size, shape, then canal curvature and number. Okay, so size of pulp chamber. In young tooth, the size of the pulp chamber will be extensive. You can say it is 5. And in the old patient, the size of the pulp chamber it gets diminished due to the secondary deposition of dentin. Next is shape of pulp chamber. Shape of pulp chamber it changes with the tooth. Here, this is a central incisor. The shape of pulp chamber will be triangular. Here it is a premolar. The shape of the pulp chamber will be oval or similar to oval, that is ovoid. And for the shape of this molar, it is triangular. Okay. The next principle, the outline is just now I told you number and direction of the root canals. Okay. So how many numbers of root canals we have? How is the curvature of the root canal? This comes in the outline form. See, to do an axis calculation, you should know proper morphology of the axis cavity. If you don't know the proper morphology of the pulp chamber, how is the pulp chamber, how many roots are there, how many root canals are there, all of you know for mandibular first molar. Basically, one root is there, but canals are two. So you should know this type of variation. So to do an axis cavity, to do a root canal, you should know properly pulp. If you don't know pulp, if you don't know root canal, you are not able to do, you won't be able to do the proper RCT. Am I clear? So to learn RCT, you should know proper pulp and pulp morphology. So here we just discussed that in outline form, axis cavity outline form, see in axis cavity, first principle is outline form. Outline of your axis cavity will depend on the size, shape, number and direction of root canal. Am I clear? So outline of your pulp chamber, it depends on size of pulp chamber. Suppose in young patient, the size of the pulp chamber is large, so axis cavity is large. In older patient, the size of the pulp chamber is small, so axis cavity is small. Am I clear? Similarly, your axis cavity shape will change depending upon the which type of tooth you are treating. If you are treating a central incisor, then shape of your axis cavity will be triangular. Here you can see that this is a central incisor and this is the cross section of central incisor. This is the incisor edge. So here if you take a cross section of the at the C junction of the central incisor, it will be like this and the axis cavity shape will be like this. So here it is triangular. So if you take a cross section at the floor of the pulp chamber for the central incisor, you can see like this. If you take a cross section, you will see this is the incisor ledge and this is the triangular axis cavity. So base of the triangle is towards the incisor ledge, apex is towards the cingulum. If you take a cross section of premolar at the C junction or at the floor of the pulp chamber, then you will see the axis cavity will be having the shape of oval. It will be oval or ovoid, like a oval. Ovoid means like a oval. So if you take this, the pulp chambers shape of axis cavity will be in the premolar will be oval shape. Shape of axis cavity in molar it will be triangular. Am I clear? Then number and direction of root canals. Okay. See, here you can see that it is a molar and it has a 3 roots. Okay, here it is a second molar. So here it have a 2 root canals. है ना? Here you can see this is a upper molar and here you can see 3 root canals. Okay, this is major buccal, this is distal buccal, and this is palatal. Okay, so outline form it depends upon the number of roots and its direction of roots. Convenience form. As just now I told you, convenience form, it is for greater visibility, it is for better disinfection of pulp cavity, it is for better obturation for the root canal. Okay, so better visibility and better operational quality of the pulp space cavity, we do this convenience form. Like your cavity preparation, we have the principles for your axis cavity preparation also. First one is outline form. Outline form depends on size, shape, number and direction of root canal. Size is big, axis cavity will be big. Size of the pulp chamber is small, axis cavity will be small. Number and direction it will also affect. Suppose it is a second molar. Here only 2 canals are there. The shape will be different. Okay. Next is convenience form. Why we need a convenience form? It is for better visibility, and we need to see what we will get better visibility, better cleaning and shaping, and better feeling of root canal. Here, these are the aims again. Additional to that, there will be the unobstructed access to the orifices. So, if you do a give a proper convenience form to the access cavity, there will be unobstructed access to the orifices. In previous thing, here you can see, here this is the instrument. It is obstructed here. Can you appreciate over here? It is obstructed here. Actually, we have to cut this portion so that instrument will get a straight line access to the apical foramina. I told you in the pulp chamber area, your instrument should be straight. That is a straight line access. So that's why here it is dotted it has shown. This is the proper cutting. So this is not a proper cutting. Here the instrument is deflected. Am I clear? Here the instrument is deflected. The instrument is not getting the proper, what you say, proper access to the apical foramen, and that's why this instrument, instead of going here, it is going on the lateral aspects of the canal, and this is going to create a complication. Am I clear? So what I telling you is, here the instrument should be straight. In the pulp chamber area, it should be straight. This is called straight line axis. Instrument in the pulp chamber area, it should be straight so that you will get a straight line axis to this apical foramina. Here there is an obstruction, and because of this obstruction, your instrument cannot go straight, and here it is, instead of going to the apical foramina, it is going straight and it is causing a complication. It is going somewhere else. So this is not an unobstructed axis cavity preparation. Next is, if you get an unobstructed access to the orifices, you will definitely get proper access to the apical foramina. Orifices, they are in the pulp chamber. Apical foramina in the apical area. So if you get a proper unobstructed access to these orifices, you will get a proper access to the apical foramina. So, if you get a straight line access to the apical foramina, you will have a good tactile sense. You can feel your apical foramina. So, your instrument can feel what is the curvature of root canal. You will feel the obstruction of apical foramina. So, in general, you have a better control on your instrument. So, you will have a complete authority over the instrument. So, you should have direct access, unobstructed access to the apical foramen. This is the aim of your access cavity. If you get a direct access to your apical orifices and in your coronal one-third, you will get a direct access to your apical foramina, and you will have a better tactile sense of the instrument. And as the cavity is wide, whatever instrument, whatever what you say, disinfecting material you are using to disinfect the pulp cavity, whatever material you are using to fill the cavity, you will get a proper accommodation of that material inside the pulp chamber. Okay. As the cavity is big, the disinfecting material accommodation in the pulp chamber will be more and the feeling of the material will be proper. So here you can appreciate, see here this instrument is again obstructed. So this is not a straight line axis. I told you your instrument should be straight in the upper, in the coronal 1/3 area and in the what's your in the pulp chamber area. Now you can see here the instrument is straight. This is unobstructed access to the apical foramina. This is the straight line access to the apical foramina. Okay, and here it is obstructed, so instrument is deflected. So in that case, errors are more. Errors are more. You won't get a proper control of your instrument. So Knight's principle is removal of remaining carious dentin. Once you finish, you get the access cavity, and once you get a straight line access to apical foramina, remove all carious dentin and remove all defective restoration. See, carious dentin, it is removed to remove the bacteria, to remove the toxin, to remove the soft dentin, to remove the soft enamel. Okay, that is infecting. And also, if you don't remove the infected dentin, infected bacteria, toxin, your pulp cavity will again become, what you said, your pulp cavity will again become infected because of this bacteria. So what is the aim of our root canal treatment? We have to remove the necrose or damaged pulp, infected pulp, and then we have to disinfect it, and then we have to obturate it. Means that we have to fill it. If it is infected, if we keep some carious dentin inside the pulp chamber, what will happen? It will get again infected. So the procedure will be a best thing. So next step is to remove all carious dentin. Why we need to remove the all carious dentin? To remove the bacteria, to remove the toxins. Also, we have to remove the restorations also, because while doing the instrumentation, this instrument may get chipped and they may block the canal orifices. The canal orifices, they are very tiny things. They will have almost or less than 1 millimeter diameter. They are this much small. Suppose we have a fracture amalgam restoration and we don't remove it completely before the access cavity preparation. What will happen? The silver amalgam will get blocked in the canal orifices and you are not able to negotiate the canal properly. So first of all, you have to remove all defective restoration because it may get fracture during the instrumentation of that pulp chamber and during the instrumentation of that root canal. So remove all defective restoration. Other than this, we have to remove all discolored tooth structure. Okay, discolored means they have some toxins, isn't it? There are two types of dentin, affected dentin and infected dentin. Infected dentin, it has bacteria and that's why they are soft. Okay, but affected dentin, it doesn't have bacteria, but they have a toxins. So we have to affected dentin. How we differentiate by color wise and feel wise? Affected dentin, it is strong, but it is discolored. Means what? It is not completely demineralized, but it has some toxins. Okay, so we have to remove that also. See, doing this, what we are achieving? We are achieving a good seal also. Whatever material you are going to fill. Okay, 1 second. Huh? Jadhav?